live. Hello, America.
It's a weird time, guys. We know it's not our normal time. There's
Yeah,
reasons for that. There's reasons for that.
yeah. Even our special guest is not here on time, and neither is Melissa. So here we are. This may or may not be the last show of 2025. We don't know, but we
We
suspect
don't know.
yes. We
We don't
suspect
know.
yes. We also didn't do like our greatest hits of 2025. Maybe we'll do that in January.
We'll do it
I
in
don't know.
January, probably. We'll be like, what happened?
Do you
Dear
know? Okay, so
Lord.
speaking of January, oh, by the way, this is the Health Tech Talk Show with Lisa Berry and Kat
Hi.
McDevitt for our listeners on the podcast. Actually, okay, two things. Have you seen that people actually listen to our podcast?
No, but we know some of them personally, so I have to believe it actually happens.
No, like people actually listen to it.
Weird.
It's
Weird.
so weird. And
I'm
then
sorry, everyone.
two,
I'm really sorry. But
yeah, sorry, because I'm positive it's not the best podcast because this is a
no.
video internet TV
Yeah,
show.
no. Yeah.
So
Yeah.
whatever. Yeah. But the second thing is, Lisa, do you remember who our first guest of 2026 will be?
No. Oh, yes, yes, I do. Yes. Do you want to announce it?
Yeah, you announce it.
Becker, Scott Becker,
Yeah, Scott Becker
right?
is coming on our show. Oh my God. That guy is like the OG LinkedIn poster.
Listen, Scott Becker and the Becker's media empire are like levels that we would only ever dream of aspiring to. It's a big
Do you
deal.
think one day we will be like the Becker's healthcare media, whatever they're called? I think it's just like Becker's healthcare, and then it's all the sub brands. I mean, we can only hope.
I have no idea. I can't imagine we'd ever have that much patience or focus or funding, but maybe someday. You never know. Who
Yeah,
can
maybe
say?
one day. We never know. Anyway, okay, so there's a lot happened this week. Ann Zink is our special guest. If she shows up, Dr. Ann Zink, former
She was
CMO of a
trying to
great state of
join just a
Alaska.
second ago. I think she's having some issues. Oh,
Yeah.
we gotta. Oh yeah, I don't know. She's coming.
And,
We'll
and
see. TBD.
you, but it says device is not connected. I don't know. We have 30 minutes to figure that out. So hopefully, yeah, I don't know, text us or something. Also, LinkedIn user just pre-ordered Scott Becker's book. So yeah, also America, Scott Becker has a book coming out in June, I think. So like go on Amazon and pre-order it. And I think he's going to tell us what the book's about when he shows up, most likely. I don't know. But anyway, we like that guy. So yeah, a lot happened this week. It was pretty wild. Who's private chatting us? Oh, it's Anne. LOL.
Oh,
I don't know
Anne's
how
having some
to.
problems. Will
It will
not let
not.
me connect camera. That's a problem, man. We are not sure.
And
Try another browser. Try your
yeah,
phone. Try another browser.
yeah.
Um, Browser,
Um,
computer, phone, etc.
it's unclear.
We don't have any tech support today, so it's really just us, and that's not a
Yeah.
good sign.
She says, we'll be trying. Hold on. I believe that Anne will show up to our show. Anne, we were going to put you in the back of the studio until she's gone now. Whatever. Okay. Well, whatever.
It's fine.
Anyway,
It's fine.
okay. Okay. So a lot happened this week. Lots of news, a new CMMI model, some lawsuits, some settling of lawsuits, very exciting stuff. But to kick off, Lisa, it sounds like marijuana we're loosening our federal restrictions on that. I don't know.
Yeah. Breaking news, everyone. Apparently, after being much noted, it seems like the president is going to do another executive order or do some kind of direction to the DEA and other agencies to reclassify marijuana as a Schedule 3 drug, which is like painkillers like Tylenol.
Over the counter. Well, Tylenol, Lisa, causes autism, so I hope it's not
It
like that.
does. It does.
Oh my gosh! Here, let's bring in. Let's
Hey,
bring
we
her
did
briefly
it.
here. Oh my
Hey,
gosh, Oh my God, Anne.
Hello,
Hi.
hello.
Okay.
you
Hi.
did it. It's good because
I
we
got
have
it.
no idea how to fix a problem.
Yeah,
No
I was
medical
clue.
gonna get
doctor Anne
there.
Zink is here. She did that. Okay, Anne. Here's the thing. We got to go through our news show. We're going to put you in the background so you don't get sued for random stuff we say. I don't know. And then we'll bring you on to talk about health data. So good news, America. Anne Zink has actually joined us. So you're going away now. Okay. All right. Anyway, yeah. So yeah, but okay, Tylenol, marijuana, same thing is what I heard.
Yeah, I mean, and here's the thing, right? Like, I am actually like over many years and of my life living in California, like a little bit more negative on cannabis. I don't like the name marijuana; it's kind of a dumb name for this drug. I
Yeah.
think cannabis like has definitely like gone like jumped the proverbial shark. Here's my opinion, everyone, right? In terms of like these like synthetic forms, like all of these gummies, all of these like cannabis products, right? It is very, very different than it used to be back in the day. So I am pretty negative on it, but at the same time, like I don't think it should be a like Schedule 1 drug. Like that's stupid, right?
Yeah.
So
Yeah.
I'm supportive. You know what? Make it happen. Let's do it.
I'm supportive of choices in most areas of life. Yeah, but to your point, as a good friend of both of ours has once told me, don't do weed in a blue state. It's not as God intended. So I don't know. I guess now it's going to be
Listen,
nationwide. Don't do it because it's
Listen,
beyond
guys,
the
you know what?
original intent.
Drugs are drugs, no matter what they say. Caffeine, cannabis, alcohol, tobacco, these are all drugs. Like, don't do drugs, kids. This is your brand of drugs,
Yeah, don't
whatever.
do drugs.
Like,
Don't do drugs.
I
Yeah,
mean, I
don't do
obviously
drugs.
drink a lot I consume a lot of caffeine, just to be totally clear, but
Yeah,
whatever.
yeah,
It's not good
yeah.
for you. To be
Anyway,
clear.
moving on. Okay, so there's like a lot of news, some of it which is healthcare related, some of which we just like the graphics for. So apparently, the Trump administration is very into the talk shows graphics, is all I have to say.
No,
Like,
this is the reason why we are showing this to you guys is because the graphics are out of control. They are truly there. That is an eagle at the top on this web
so
page.
good.
There is a interactive like eagle graphic whose head moves when you scroll. This is
Oh my
like
God.
truly. I have to assume that they were taking inspiration from us. I have to assume.
I 100% agree. And sadly, America, we never can figure out how to share our actual screen. This is just a screenshot. When you scroll on this page, the Trump
Dude,
card comes up. Like, oh,
holy
just please go there now.
smokes.
It is beautiful in so many talk show graphic ways.
Like there are so many
Anyway,
things wrong with this, but the graphics and the website are
yeah,
freaking amazing. Like
can't
strong
comment
support.
on the policy here
Right.
because
But the
this is
graph
the health tech talk show, and we don't comment on immigration.
Oh my god.
But
No.
yeah.
Holy
Anyway, go check it
smokes.
out
Yeah.
now. Is all I
Wow.
gotta
Wow.
say.
Wow. Just
Um,
really quick, we have a shout out for
oh
THC and cannabis. And I agree exactly. Like there totally are real medical applications for THC, the psychoactive component of cannabis and hemp in some cases. That truly this the reason to reclassify it is to do better research for clinical 100%. This is the reason why. So
yeah,
I agree, my friend.
yeah. Um, Also agree with our friend LinkedIn user, who I think is Erica Olinsky. It's unclear. I don't know why it's
We
not.
don't know why it
Well,
shows up
some
as
people
LinkedIn
don't
user,
show up for
guys.
us. I don't
We
know.
don't
We're probably
know.
getting
We don't
blocked
know.
for like explicit content. Anyway, we have several palette cleansers throughout our deck today. One of them is these from one of Lisa's many productive group chats.
Yeah, thanks, Jen, for sharing this one. This is so if you recall, like back in the day, when like Dr. Google, if you go to the doctor and you say, "Look, I Googled it," they'd be like, "Do not confuse your Google search with my medical degree." And now, obviously, someone has updated this for the modern era with my open evidence subscription, which I think is freaking hilarious.
Yeah.
And great point made. Thank you.
So
Thank you.
also, we haven't talked about the Doximity open evidence situation in
Mm,
here, right? But I mean, go read Brendan Keeler's posts, I guess.
yeah,
They're pretty,
yeah,
I think they're
yeah.
pretty funny. But now about the dialer and how they're all competing and like whatever.
Yeah. Well,
Yeah.
also, of course, just to be clear, this is also part of that quote unquote debate of like, should patients have access to open evidence? And patients and patient advocates are like, yeah, we can handle it. We promise. Don't keep it from us. So
Yeah.
it's an issue.
Yeah. Anyway, great image. Okay. What do we got going on? Okay. Matthew
Oh
Holt,
man,
not to be confused with the
Matt
private
Holt.
equity Matt Holt. Matthew Holt got canceled. Lisa, I thought your comments to this were hilarious, and I thought in general Matthew Holt, I think his stuff is hilarious. So tell us about what happened to our dear friend here.
Yeah, I mean, this he has been very bravely writing about his like fighting like endlessly with both like the medical system, the healthcare system here in the Bay Area, and then also with insurance. And he got his insurance got canceled for like a
Mm,
totally unclear reason. Like if you like click one thing wrong ever in your application, they will eventually go back like potentially years later and be like, oh yeah, we just caught up to this. You did this wrong and you're canceled. And it's like, okay. But yeah, he's chronicled in the healthcare blog like his travails through a bureaucratic insurance nightmare, and recommend reading it. But yeah, I think he fixed it. We think he fixed it, but it's really scary when like you think you have insurance and you get sick and you need something and then you don't. Like, not a great situation.
Yeah. Well, speaking of insurance, it looks like Obamacare
What?
subsidies are like not happening. So basically, these are pandemic era subsidies. They were enhancements. However, like that was like a long time ago, and people are now
Mm,
used to this being the cost of their insurance, which has increased anyway in cost. And so it looks like both efforts to, I think, both the Republicans and Democratic versions of bills to salvage some sort of semblance of a subsidy for exchange insurance plans have failed. So we are not going to have Trump freedom accounts, I think is what they were called. Also, like appreciate the talk show
amazing.
naming methodology there, as well as just like giving people subsidies. Both of those have failed. So appears unlikely we'll have a solution according to the internet.
Yeah, if you go back in time just a few little short weeks here, you may recall that the Democrats kind of just like folded without any kind of commitment. And unsurprisingly, as everyone said would happen, nothing has happened on making healthcare more affordable in 2026. So here we are. Maybe next time, do a better job negotiating. Good job, guys. Just kidding.
Yeah. Yeah, not great.
Shocker.
Also, our girl Lisa, this is not a great photo of her. I mean, she's happy, which I'm here for. I just feel like it's not the
I don't know
greatest
why she's
photo
happy. I don't know why she's
aligned
happy.
with the headline here. It's
Yikes.
probably, who
Yikes.
knows? Well, maybe they were talking
Probably
about the
unrelated.
coffee. Probably
Right?
unrelated. Yeah, I don't know. Anyway, all right. So Lisa and I, everybody knows we like Joe Rogan. We've like been on his show. We're going back on his show. He's coming on, or he went
GR,
on our
guys.
show.
Before anyone
Not
asks again,
Rogan.
not Joe Rogan, Joe
Joe
Rogan,
Rogan.
GR. We every time someone's like, "What?" We're like, "No, no, no. Listen again,
We
Rogan,
really like this
Joe
guy.
Rogan,
We don't always agree
policy
with this
dude."
guy. We don't always agree with each other, but he
That's
had an
right.
AI summit this week that we both really wanted to go to, but could not.
Yes,
And
we missed out.
I think Mario's our friend. I will also say Mario is from a real media news outlet, unlike our fake news show, and
Hmm.
he does real reporter stuff sometimes. So he did
That's right.
cover this summit, which sounds like it was super great. Some of our buddies went, said the crowd was really awesome. So there was some panel-y content, but there was some really good stuff said. And in here, I think well, we have another. We'll talk about the Tom Keene thing next. But Jim O'Neill also had a discussion with Joe about the executive order on AI, which we'll talk about in a little bit. But the thing that I want to say is that with regard to the deregulation of health tech, with us moving from certifying EHRs, certifying APIs, Ryan Howells is trying to say that was his idea. First of all, everybody knows we've been saying that for like
Yeah.
years,
Check
and
the tapes, man.
I mean, come on, Ryan, come on, that was us.
Check the tapes.
Check the tapes.
You can find out. We've been calling for the elimination of the entire ONC for a long time. Also,
Yeah,
you know,
we were like, remember we had our abolish the ONC program. Not that we don't love the ONC, we're just saying like maybe it should go to different.
and
I
also
don't know.
Dr. Keene, Tom Keene has really defied all expectations to be an awesome assistant secretary for technology policy slash national coordinator for health IT. And also noted fan of the very disreputable health tech talk show.
Yeah, fake news show.
But fake news show.
Yeah.
But check the tapes, Ryan.
Yeah, check the tape, Brian. I mean, okay, yeah, agree. Dr. Tom Keene, medical doctor Tom Keene, actually does seem to be pretty legit, and it's like according to sources close to the Health Tech Talk Show, fake news show, we have been told that he actually has always been pro deregulation. So who knows? It might actually be his. It might actually be his own idea. Who knows how that all happened?
Who can say? Who can say?
But
Who can
to
say?
be clear, the Health Tech Talk Show definitely talked about it before. Kill the clipboard is all I'm saying. That's
But there's actually, if you go back, there's something important for any loyal fans to know, right? This is very important. ONC historically was known as the Office of No Christmas. And as you can see, they plan to be the Office of No Christmas again by releasing the deregulatory rule, which I believe is now HTI 5. I can't keep track.
I think it's 5.
And
Yeah.
whatever, 5, 6, 7, 8, 9, 10, who cares? They are going to release this before Christmas, meaning once again, they are fulfilling their destiny of being the Office of No Christmas, and they are going to deregulate certification and maintenance and all that good stuff around health IT. So yay, more soon.
Yeah. Yeah. So you
Good
see
thing I have no
here.
plans for Christmas. Good thing I'll just be sitting here reading rules.
I
Thanks a lot, ONC.
mean, it's good to have
Whatever.
traditions. It's good to have traditions
Sure,
in
for
life.
sure, for sure.
You know,
Very tradition
um,
oriented
yeah,
office.
100%. Also here, Mario does report. I think this is actually the first I've heard that they were doing this, as we all know, and since it was our idea anyway, Lisa, obviously. But like, here is the first time that I've seen a number released about how many certifications would be abolished.
Cool.
So they're going to release the rule to eliminate 34 certification criteria for EHRs and modify 7 others. So that's very exciting. I will say the only thing that bums me out about this HTI-5, I'm looking forward to seeing what it actually says, is that like, why do we have so many regulations to deregulate? Like, I mean, I guess like you kind of have to have a regulation to cancel some regulations, but it would be nice if they just like stopped making them for a little
They don't
while.
make the rules. They just
Yeah.
unmake the rules, I guess.
Well, it's good to have like we're saying, maybe it's good to have traditions. I don't know.
Sure.
Anyway, I do like how Mario was nice about Ryan claiming credit when it wasn't
Nicer than
obvious.
we were. Shoot.
Okay, another palate cleanser. Dr. Oz tells employees of HHS to eat fewer cookies.
This is just so mean. Basically, it was like there's like a cookie exchange or something. And he was like, "Hey, you don't have to eat all the cookies." Cool. Like,
Yeah, yeah. It was like
in fact, Dr. Oz, I do have to eat all the cookies. I am not a
yeah.
federal employee anymore, but in fact, I do have to eat all the cookies.
Use it like he gives very practical advice that I sometimes would read in Cosmopolitan and 17 magazine when I was younger. Like use a smaller plate and like only sample a part of a cookie or not all the cookies. I would just say like I don't really know if this is cool or not, but I do think it's hilarious.
Great.
All right, what we got next? All right.
Well,
Got sued again.
loyal Health Tech Talk Show fans, this is an issue in which Kat and I vehemently disagree.
We
We
do.
had a fight about it this morning. We almost broke up. Um, in case you think that we like actually secretly agree on everything, we do not. We do not. We disagree. And that's what makes it so interesting. But yeah, we almost broke up over this one. So yeah,
Yeah.
Kat, say your wrong
So
opinion.
here's my okay. I mean, maybe it's wrong or maybe it's right. I will say that like I often pick winners in court battles who like gloriously lose. Um, okay, so but on this one, so I just want to set the stage. I also did not believe that social media companies should be responsible for like bad content on their platforms. I'm like that person, right? So just keep that in mind. So here, Texas, the Texas AG is suing Epic, saying that it's for monopolistic behavior. The reason that here's what I disagree with. I think there's lots of reasons you can sue Epic for anti-competitive behavior. The reason in here is that the state is saying that there is a pediatric hospital that patients' parents were not able to access their records off my chart if they were over 12. And the AG is saying that this is clearly Epic not wanting to share data and wanting to block access. Epic is saying that's a configurable feature by our customers. That's actually like not us.
Yeah.
I
Yeah.
agree with Epic here, 100%. But Lisa, I know you do not.
I don't. I mean, I don't know where it's going to land, but that issue of whether it's Epic or whether it's the customer's configuration is not a straightforward one that will be debated in court most likely, unless for some reason this is just like dismissed out of hand, which it totally could be, right? We've seen all kinds of stuff happen this year on law. And by the way, Brendan Keeler wrote something today, a long piece about this as well. There's a ton of other
Oh, what do you
news
say?
coverage. You should see he has a whole long post about it just released today.
Unless
You
you're
know,
working today, such a
yeah,
problem.
I mean, he must have been working like 24/7 overnight to get this written. But the thing is like my point is like that issue is not as black and white as you make it out to be, and that will be debated in court should this actually go to court, go to trial, go to discover, whatever else it is, right? Like these are arguments that are going to be made in the legal process because it's not straightforward. The state can say cool, Epic, but you make it possible for your customers to break the law, right? And then Epic will say, well, we do, but everything's configurable, and the legal responsibility lies with the health system in mind, right? These are reasonable questions, and the intent and the level of configurability and the way that it's structured, the way that their training documents or their implementation these things will all come to play. And it's just, what I'm saying is it's not straightforward. Now, the other thing about this, of course, is that in reality, this is an argument about antitrust, an argument about blocking data that is wrapped around an issue around trans kids, around medical care for kids and youth. And so, again, like, right or wrong, like, the story from Texas is very much about that, and they're wrapping around at this antitrust and interoperability issue. Now, I think the antitrust and interoperability issue is really interesting and important. I'm not sure I agree with the direction of the Texas AG on, care for kids, but like the broader issue is interesting. We'll see, right? This is my point is just that it's not that straightforward. I don't necessarily agree that a software company has like no liability or no responsibility, and I don't think that the court's going to agree either.
Yeah, I think that like some of this is like, okay, so when we have the criminal groups in Florida committing DME fraud, do we sue the RCM vendor, which has features that are configurable that do allow them to submit fraudulent claims, right? Like,
hey, in America, you can sue everybody, Kat. You can sue everybody all the time.
You can sue them, but like, are they liable for that fraud? I think no.
So Michael Marchand says holding a vendor accountable for how the customers use the product and suing gun manufacturers, cigarette manufacturers. And by the way, that has worked over time, so it's not that straightforward. And then
usually for bad marketing address, usually not for their product necessarily.
Right. I mean, Epic isn't like advertising like, here's how you restrict parents' access, whatever. Yeah. And then this is funny. This is the funny comment, which is how easily is it reconfigured? How much does it cost? Well, the answer is 0 to a trillion. Michael says it is just a button menu item, but I just have to laugh. How much does it cost? How much money do you have?
And it depends on the state too. So I understand Epic's point here, which is that like different states have different. Like I think in the complaint it says that in Texas, parents have access until children are 18. So sounds like this. I mean, and that could also be a thing too. Is this hospital actually knowingly breaking the law because of trans minor care and things like that? Should Epic be routinely policing its customers to ensure that they adhere to state law? I think no. Because in other states, this law does not exist, right? So it should, who? I think the burden's on the hospital. Like, sorry, y'all, like follow your freaking state rules, and if you don't like them, like I don't know, like lobby. Move. So I don't know. Like Epic. There are plenty of things I don't like about Epic. Like I hate that they regulatory capturize all of TEFCA and that it's still around because of them. That is super frustrating for me. Not interested, but like. This seems pretty weak. Like there are probably lots of other reasons that they could have sued Epic for anti-competitive behavior. And I just don't think this is good.
Well, maybe we'll have a real attorney who actually specializes in antitrust talk about it at some point, because it's not us, certainly. To see if the rest of to see if the rest of the argument is valid. I'm really surprised in general because like I don't think there are any Texas like hospitals or clinics that are providing like trans affirming care to kids at this point in time. So I wonder what this is. I obviously haven't read it, so I don't know. Maybe they actually said that in the complaint, but I'm just wondering like who's actually even doing this in Texas. I can't imagine it was like intentional because the law has been pretty clear in the state for a while.
Yeah. I mean, honestly, is this just someone who didn't, okay. Michael Marchand is he works for Epic. Apparently he knows all these things.
Michael makes a good point here though. One of the things that Epic does do, which I think a lot of people actually do have problems with, is that Epic rewards like in the form of gold stars, honor roll, generally like making public, also reducing cost for their customers who implement things the way that they want them to be implemented, right? So Epic is trying to use like a cost mechanism and also a like social pressure gold star situation to get their customers to implement in a more standardized way. It's something that I've been concerned about in the past as well and seen. So, there's all these factors that matter here. We'll see.
Well, hey, Michael, do you get a gold star if your my chart is great? Like if you like are age limits and all, like, is this something like they care about, or is this such like a sub feature? Like Epic's so big. I don't know. I have a lot of in
Yeah.
general, I have, and I also like work for a consultancy. Like Epic isn't being mean to any of my clients right now, right? Like whatever. Um, so I'm kind of like, well, I kind of understand. This seems like a really small thing. And again, like go after him for something good. I'm confused. I don't know. I don't work for Epic, but did stay at a holiday. That's what I'm talking about.
That's right.
Yeah, I don't stay at Holiday Inns unless I have to. Okay. So speaking of laws and state laws and all those things, so last night, I actually don't know if we disagree on this, Lisa. Everybody saw last year in the Big Beautiful Bill, they cut out the moratorium on state laws around AI. Now we have an executive order on it. AI state law is like not a thing anymore. We're just doing the federal stuff. We're just going big or going home. Big boon for tech companies. Obviously, state laws are hard. There were allegedly over 1,000 different bills floating around in the states regulating AI. Some of them weren't as serious as people said, as I think, actually, our friend Christian Robles from,
Inside Health Policy.
Inside Health, Inside Health Policy, talked to someone who said, like, allegedly, like some of these were just like laws setting up advisory boards and things like that. But a lot of activity here. Lisa, how do you feel about this?
I don't like it.
I freaking hate it. I'm like so mad about it generally.
Listen, I think one of the things that like is very unique about the United States of America is that like any law that isn't like specifically given to the federal government is given to the states, like is left to the states, right? The states are themselves, essentially these many little sovereign nations who've decided to work together under the US federal government. And I don't like us trying to have it both ways. Either we believe in the states and the Constitution, or we don't. And
yeah,
I don't love it. And listen. I understood on all fronts, right? Like I get as somebody who works for a tech company, I get that it is very, very hard to like deal with like a bunch of different laws. But like, I'm sorry, it's not you just saying like, I'm just kidding, we're taking it away. And by the way, as well, like we tried to do this from a congressional point of view in terms of like passing a law and including this in a law. It didn't work, right? There was a lot of pushback. Executive order is not exactly the strongest way to do this. And I guess I wonder, how meaningful this even is, right? I feel like, states and tech companies and whatever else can just be like, well, executive order isn't a law, so not really sure what we can do.
I mean,
laws are laws.
I agree with that. I think for me, this is like a very philosophical question. Like, what is the role of government? What is the role of the federal government? And again, we had Nora Cox on here talking about the freaking 10th Amendment, right? States' rights. We also have weird things, like we did have the federal cannabis rules, to use your parlance, Lisa, and then states, right, doing whatever they wanted. And I think one of the reasons a country
it caused a ton of problems. It's been horrible.
Like, that's the thing. Like states are still going to pass crazy law. They're still going to do it. They do it all the time, and it is annoying. But it's like, what are we trying to do? Are we just trying to beat China, which, by the way, wins by having a hyper centrally planned government where you do what you're told? Are we competing like? Are we apples to apples competing against China? Because I don't agree with that. And also, like, one of the reasons our country is great and we have awesome innovation is we do have these little test beds, and some things work, and the states compete against each other too. And competition is great, as the Texas AG believes. So I'm like I'm so sad that this happened.
We had a lot of commenters talking about, the national security aspects of this. I get it, but you know what? At least the way I last understood how the country is supposed to work is supposed to pass laws. And those laws are supposed to be things that we, debate and negotiate across our various House of Representatives, Senate, and people you can vote for, and the way you can express your perspective through your elected representatives, and the way laws actually happen, and how they have to be legal, and all kinds of stuff that we don't do a lot of anymore.
We should.
So I would just say
the video on our website.
Law.
I feel like this one was great because the last one is about you talking about the Chevron rule of being overturned. And like this one was just like it was like great. We're gonna cut it again.
Great.
Yeah, I agree. I am like, listen, all y'all complaining about national security. I am here for being the best, 1,000,000%. I think there are lots of ways to be the best. And one of the reasons we are the freaking best is because of the states. Like, that's why we have Boston being a biotech hub. We have Austin being a tech hub now, right? Like, we have San Francisco falling from its former glory, right? Like, all these states did things to like attract investment and make innovation happen. And I just don't think that's the federal government's place. But you know what? I am often wrong and never in doubt. So keep those comments coming. I don't know. We'll see.
Great.
Next. Oh, like more lawsuits. We should have had a palate cleanser in here. Oh my God. So this was actually super, everybody was actually really excited for the outcome of this lawsuit, RTMS versus Point Click Here, information blocking. It looks like they're going to settle. So we won't know a lot of stuff.
Everyone was very excited for the discovery and everything to become public and whatever, blah, blah, blah. Like, fine.
Yeah.
But yeah, I mean, this is the question right now. Like where does information blocking stuff get like worked out in courts and state courts and like private action? Is it going to come from the federal government? Did you have in your slides the OIG hiring like 5 information blocking attorneys?
No.
I had to laugh at that one.
But that's happening,
They basically came out with like a job rec, and they're like, we're hiring like 5 information blocking attorneys, like must have experience with like information blocking law. I'm like, okay. I was also kind of like, if you're hiring your information blocking attorneys now when enforcement was supposed to start like X number of months ago, that concerns me. Let's get going, guys. We need to do something.
Yeah. Well, I don't know. They could just use ChatGPT to figure out.
Yeah, sure. Perfect.
Who's info blocking. They don't even need it. They don't even need those people.
They can
anyway, okay. New CMMI model. We had the Access model the other week. Now we've got Elevate. This is all Maha stuff. This is actually called the Maha Elevate model. Apparently there's going to be like 100. Is it 100 companies that are
organizations? No, it's like 30. I think it was like 30 cooperative. It's like 30 cooperative agreements, which is very interesting because they're very cooperative agreements are more like
and
collaborative
$100 million.
use of funds.
That's where the 100
something
is,
like
right?
that. Like each like awardee, each cooperative agreement is like $3 million or something, and they're trying to like fund, this idea of things that are not covered under original Medicare. I assume that means like exercise and nutrition counseling, although some of that is covered under original Medicare, not all of it. Like just things that go beyond what is already traditionally covered. I wonder about this because Medicare Advantage already has the flexibility to add things that are not covered by original Medicare, right? These supplemental benefits. Is this just a test of bringing like supplemental benefits to original Medicare? I'm not really sure. I basically very, very minimal information is out there yet on this model. Speaking of access, we're also all still waiting for the full like participation agreement and plan, including like how they're going to measure the outcomes for access and how they're going to pay on that, like this one exactly. I don't know. I don't know if this is still Erica. I don't know. I imagine like some patient advocacy services actually are already covered under original Medicare. So I'm not really sure what they mean with Amaha Elevate, but we'll see.
Yeah. I don't know how I get this little screen off the side here. Do you see that? Or little comments?
You just did something. Yes, you did. Yes, here. I don't
freaking know. Okay, great.
It's that thing that says show comments on stage. You can turn them on. You can turn them off. Ooh.
Look, we learn something new every day on the Health Tech Talk Show. Okay, well, amazing. So the only new thoughts I have on this Access plus Tempo thing, mostly just the Access model, honestly, is that we were texting or slacking or signaling about this yesterday, Lisa, and I was just like, there's some companies that I think are super shady that are definitely going to enroll as Part B providers. And then, I was actually like reading, which is something I don't do super often, but talking about how Medicare beneficiaries can actually enroll directly with some of these new providers under Access. And all I could think was, holy shit, the D2C marketing that's going to go out and like all of this shady practices to acquire patients, y'all. Like, we think like marketing for MA is bad. Oh my God. Can you imagine? Because some of these companies are super shady.
Yeah,
It's
not
gonna
my
be
company,
crazy.
but some of them are very shady. No, I mean, listen, a lot of money is already spent advertising to Medicare beneficiaries. As we all know, if you've ever watched television late at night, on the old channels, you will get a huge amount of advertising directly to Medicare beneficiaries for Medicare Advantage, for devices, for all kinds of things. There's like phone spam, there's TV spam, there's mail spam. And yeah, I think that is going to be a problem. Not great.
Yeah, yeah, not great. Also, marketing to PCPs, right? So they can. I think PCPs can be the referral source,
Yep.
or beneficiaries can enroll directly. I think, like,
Hmm.
dear CMMI, when you are writing this thing, please think about aggressive and potentially lying and deceitful marketing to your beneficiaries, some of
Yep.
whom may
Exactly.
not be as health literate as they could be. Just saying. Thank you.
Yeah. Totally.
Speaking of, well, we didn't talk about the tempo thing. I think people are really excited about that, but it looks like we're finally going to get someone in there over the drug center at FDA. Some people seem excited that they'll have someone. Some people are like freaking out. I don't know. I don't deal too much with the FDA, so I don't
Yeah, I mean, listen, you ideally want people in those roles who are like generally supportive of the work of the agency. And I think there's been a lot of people floating around the FDA who do not believe in vaccines, who have,
know. Yeah.
different views on some of the things that FDA actually regulates. I don't love that, but you know what? At this point, nothing we can
Mm-hmm.
do.
Yeah.
That's how the cookie
And also
crumbles.
reduction in the number of phase 2 trials. Like, there's some good things I think going on at FDA that are going to get drugs and devices to market faster. Hopefully in a safe way still. So there's some good stuff coming out of the
Well,
FDA.
that is what tempo is a sort of an add-on to access where the FDA is giving sort of this like accelerated limited approval for some devices that may not have gone through the full process um, of approval. Yeah, good point,
Yeah.
Ron.
Yeah.
Your car warranty is expiring, and also we have an amazing plan for you that is part of your
It's
Medicare
gonna be
benefits.
crazy. Yeah.
Exactly.
Anyway, we'll see. I don't know. Like, I feel like I'm just so over changing stuff in the government that I like whatever. We'll see what happens. And then we already talked about this. I moved it up, but yeah, we'll see if Congress gets their shit together. Seems unlikely on subsidies. Yeah, we'll see. And now, moving on to Ann Zink, who may or may not show back up on camera. There she is. Oh my gosh, you guys. So the reason we moved our show to 2 is because Anne couldn't do 3, and like we love her and wanted her on the show. So
Yeah,
whatever.
that's pretty much
So
it.
this is Dr. Ann Zink. Anne, would you please introduce yourself to our millions of loyal fans?
Awesome. Thank you so much for moving it. Thanks for having me. I listen often, big fan. Practicing emergency medicine physician who got into emergency medicine work and then quickly realized doing the same thing over and over again was the definition of insanity, as Albert Einstein said, and realized that all good public policy comes to fail in the emergency department. So got angry, got frustrated, and started to try to figure out how to make systems work for patients instead of asking our patients to work for systems. So got involved in opioid epidemic, got involved in data sharing and information sharing because, looking at someone's bracelets on their wrist didn't seem like the most effective way to see if they'd been in another ER recently. And realizing that my complex patients, had 6 care coordinators who didn't know what they were doing or who was on first to be able to manage their patients, and working with state programs that were supposed to do quality coordination and they couldn't reach the patient, but they'd had over 400 visits in our ER. And I'm like, I can just bring you the phone. Like, they're right here. I can tell you all about them. So really frustrated with the way that the systems were failing patients. So that's how I kind of got to know some of you all, some other people kind of on LinkedIn, asked too many questions until I started to have to run too many meetings and stepped in as the chief medical officer for the state of Alaska. Perfectly timed 6 months prior to a worldwide pandemic. So came into that in July in 2019, and then was kind of the main medical person overseeing everything from Medicaid to public health to behavioral health, including splitting the department into 2 to try to make it be a little bit more functional, working on mental health, complex care, sitting on our board of our HIE, and then there was a pandemic as well during that time. Did that work. Also represented all the states and territories at a federal level, and stepped down that from a year ago to try to give my former self gifts. So now I work on trying to help to display data so that we can make better decisions. And thanks for whoever put that in.
I think that's Erica. I
think
think
it's
for whatever
Erica
reason, she's not
Walensky.
her. Yeah. Yeah.
Yeah, I'm doing a big project actually with Epic data, hearing you guys talk about Epic. So we are actually now the single biggest user of the Epic Cosmos data as we're trying to democratize data to make it so that people can make good decisions, and so the private sector, the public sector can work together, and then working in a whole series of other places, between supporting governors to public health leaders to thinking about vaccines to thinking about rural transformation, to try to just make these systems work a little better. So anyway, long and short overview, but
That's a lot. Yeah. Well, we are excited to have you. So, like,
it's great to hear.
Big question. So,
Okay.
why doesn't public health data flow efficiently, effectively, or at all in America?
Big question.
Yeah,
Big
just
question.
why?
No worries, Anne. Anne, solve it
Got
for
it.
us and please solve it for us. Thank you. You're on.
No problem. Okay. I can tell you why, and I can tell you what I think we need to do for it. Okay. So
Even
why
better.
no one thinks about public health. So the metaphor that I think of in public health, I always tell doctors, like, you're frustrated about an EHR, go work at public health for 2 months and you will like realize like how bad it can really be. I often felt like you were like, a catcher with no mitt, that you were just getting thrown balls at. People were like, here, catch this data, catch that data. But you had no system or infrastructure to catch any of that data and to do anything about it. So if you look at, I'll go all back here, but like 1910 Flexner report essentially broke apart public health and healthcare. And so the Flexner report wanted better, not having snake oil salesmen doing snake oil. So said, we really got to look at gold science and what do we do? Really focused on hospital care. It built up this incredible system that we have for incredible hospital-based medical care. And the country has led for over a century in that space. But it completely disconnected public health and healthcare from the systems. And we have seen time and time again where those systems are completely separate, siloed, don't even speak the same language. And we have these like band-aids, like the ACA or the 618 process or other things, or even like the head model or access, all these things you're talking about, I feel like are all these like attempts at like stitching this like really broken system together to try to make it better in different ways. This got exacerbated by things like high-tech funding that didn't include public health to be able to increase what they did. And so instead, to your point earlier about regulations, governments are like, we need to know some basic things about what's happening in public health. So it's all in these like regulations and reportable diseases that don't think about the healthcare sector, don't interact with it, and have a really hard time connecting the pieces. So I think that's part of the reason. It's just this historical structure. Then you get historical funding that then just propagates. And now we just don't, I feel like it's like the Tower of Babylon. We don't even speak the same language. And so we're just kind of all developing different things in different places. So I think we need to collect data once, use it multiple times. We need to put data in the hands of patients because it's their data and information. And I think that publicly available public data, such as population health data and publicly available data, needs to be publicly available. And so the amount of times that we spend trying to convince something, I mean, HIPAA says you can share it, but there's very few things saying you shall share it. And so to your Epic Cosmos conversation earlier, like what happens or the ways that it does becomes really limited. And so I'm hoping like even with the access regulations that they say that all these new companies coming out there and they have population level data that they have to share it on it publicly. And that would include government officials as well as others so that we can understand what's even happening in our health sector so we can make better decisions.
So that's they have talked about that they're going to publish the outcomes and they're going to publish like a list of like the providers who are doing this work. I don't know what else that means, but I totally agree with you, right? It's part of my big sort of complaint about the way CMS and other government agencies like work with data. It's like, why is it so hard for the government to use its own data and make information available? Why do you have to jump through a billion hoops and have a huge amount of money and particular types of access to, even in a de-identified way, as a qualified researcher, use the data that the government has, right? I mean, we all pay for it, right? So why are we not using it? Why are we not making it possible to use across different, different parts of the government, different systems, whatever else? Like, why are we not using those data?
Yeah, I think it's because we're all looking in our own silos and we're not thinking about how we can use it differently. I had this multi-million-dollar grant to address diabetes and our team the only data they could see on diabetes was survey data from 4 years ago if your doctor had ever diagnosed you. Yet in healthcare, it's required that you're testing hemoglobin A1Cs on a regular basis. And I'm like, how come we can't see that or know that? I
Right.
joke I could like cure diabetes and it wouldn't be shown in the public health data for 4 years because there's like no ability to see that data across the sector. So like required healthcare data should be available to those who are making decisions on population level data components to be able to improve our data, both the private sector as well as the public sector, to be able to make tools and resources. I can't like this Pop Hive project that we've done. It's really this idea to democratize data. We have Epic Cosmos data. We have publicly available data. We're working with other data. We're always looking for new data partners to share. And it's, philanthropy funded, free. It's like all just trying to democratize it so people can use the data in different spaces. But I'm amazed at how many times industry partners are like, I have a new test, but I have no idea of the prevalence. Or a patient advocacy group was like, I have no idea what X, Y, or Z. Or like even the NIH is like, can you help us to look at how much testing is happening for RSV so our models work better? And we're like, sure. And so then they look at it and they're like, great, our models work again. It's amazing to me how kind of being this kind of third party, and there are third party aggregators in there, but a lot of them sell the data and it's super protected. And like you said, Lisa, like we are paying for this in all sorts of ways, and basic population health data needs to be publicly available. And it's not for me to judge, are you the right person to have that data? I think everyone from like the governor to a patient to a business should have access to understanding the health so that we can allow the private sector to interact, that we can have the public sector interact. But we haven't set up those structures, and I think we need to lead in. And HIEs, I think, are trying to, but again, how do we do this on a more population level basis and not all this like stickiness that we get stuck in the middle of?
It's very sticky.
Well, it doesn't matter which entity does it. It just back to sort of like what Kat, will always tell you, right? It's the states, they need to decide, right? A state needs to decide, like, what do they want to do? What does Alaska want to do? How does Alaska want to make this happen? Is it through your state HIE? Is it through something else? Whatever, it needs to be there, and it has to be available at a state level. And then it has to be available to everybody who could possibly need to use it in that way. And then if states make it available, then we'll figure out, someone enterprising will figure out how to make it available to the federal government. I don't know. Or to the national audience.
Go ahead.
So here's the thing about the states in this case. States don't own the data. The facility level, it's owned by the provider. It's not owned by the patient. Everybody's going to get all moody on the internet when I say that. It's not. Patients have a right to their data. The provider owns the data. So I think, Anne, what you've done is with Pop Hive is not contracting with states to get data, right? So you've done something that, like, frankly, no one else has been able to do, right? Because either commercial interest, which I represent quite proudly, right? They want to sell it, right? Or it's only for specific uses. Their data use agreements have various uses they have to go around. The states are getting data through various public health contracts that have their own DERSAs, right? But what you've done is you've gone in many cases to intermediaries for the provider level for that data, which no one has ever done. So tell us about how you did that.
Well, I think that there's like a win-win there. I'll never forget being at this kind of post-COVID meeting and hearing, someone who works at a very large, very for-profit hospital system that said, I need CMS to regulate us better because I cannot deal with all of you 56 different states and territories because you are a pain to try to figure out how to get this information to. And like, they're totally right. It is really hard to work with that. However, like, how do we think about, like, I often think about Melissa Harvey and the NERC model for how do we think about, electricity going across. You can have all sorts of private entities who sit in there, but then you have an agreement or way to be able to understand the capacity. And so that's a little bit how I think of the data that we're doing at Pop Hive is just, it's kind of this neutral third party convener of data and data sets. I think there's real reason why healthcare is hesitant to send their information to government. And I think once you work in government, you see how much hesitation there is. They don't want to be regulated. They don't want to lose their ability to do elective surgeries. They don't want to have the government tell them how to do their business. And while you might be like, we're just public health, we don't have anything to do with that. Like, it's hard to know where those boundaries are, and it's hard to trust because there's been reasons for mistrust that have continually shown up their mind. So I think having some sort of third party component. So that's essentially what we've done with Epic. For them, it allows them to share population health data to states, to locals, to territories without them having to figure out how to do it with each and every state. So it takes off the burden for them, but then it also allows them to share like that population health data. And so that's where we're seeing like business interest in others is to kind of be like, we're this kind of third party space to say, how can we just get this out there so people share it? I also think the thing that we're really trying not to do is interpret the data. And I think, Lisa, this gets to your point earlier about states being able to be creative and innovative, and Kat, to your point about industry. Like in Alaska, like I can't tell you what's the best thing to do in New Orleans. And like people are all going to look at that data in different ways. So I see our data as a little bit like it's not ours, but we're just sharing it. I think of like Plato's truth in the cave. Each of these data sets like kind of approximate it, but we're not here to tell you the truth. We're just here to show you the different shadows, and you can look at those shadows and understand the truth that makes sense in your state with the different perspectives that you have. And I think we get too focused on this data places of trying to say like, what is the truth? But hemoglobin A1C is a very different question about, quote, truth than is have you ever been diagnosed with diabetes compared to what sort of food access you have. But they are all relevant to that truth of your overall metabolic health.
Yeah.
And I mean, data points versus trends, like these are all, there's so many factors that go into it. It's just, it's hard to find, like, yeah, I get your point. Like if you're waiting for this, like one perfect truth or one perfect data set, you will die trying, right?
Or one thing to do all things. Like, how can we collect it once, but utilize it in multiple different ways so the private sectors can engage, so public, funding can have better opportunities, so individuals can have better understanding rather than trying to have one. I mean, that's what's the beauty of our country. I mean, when I'm like, I just, Hawaii, DC, like Alaska, like all over the place, like we all just see the world so differently, and things come out as a result of this. This is an amazing playground of being able to develop and innovate. But to do that, you have to give autonomy, transparency, a place for conversation, and a place for innovation. And we need to do that with our health data.
Yeah, I think, and note of clarification for any of our loyal fans and viewers here is that this is population level data. This is not individual medical record data.
Not at all. We can't even begin to see individual data. Like you could have this tomorrow and you won't go to anything. But
I think back to the fact that no one's ever done this before. Many people have tried, right? A lot of times it's even Lisa, as you know, some HIEs trying to get federal funding for this kind of stuff. That hasn't really worked. And I wonder, Anne, is part of the reason you're able to pull this off because you are third party and philanthropically funded. That this is, something that finally happened.
I think it's a combination of things. I mean, I joke, I'm always trying to work myself out of a job. If there's something else that happens better in a different time, sure. I do think that the third party philanthropic helps. I think that the fact we're partially based at Yale helped to kind of get this started, the Yale School of Public Health. So we've got this expertise that we can tap into. So like we're looking at how do you model EHR data to better understand chronic diseases. And so by seeing the data, we can work with modelers to say, does that really work or not work? So we're able to tap into all these other resources that are hard for, a company alone to get or for a, health officer to be able to get. I also think just the time is right. And honestly, to be frank, it was really heartbreaking to see the government shut down, but suddenly we were the only place in the country where you could see respiratory diseases uptaking because we had non-government data that was there. And so I think it highlighted the importance of redundancy rather than having a one size fits all space. So, we work with the Delphi group out of Carnegie Mellon that's looking at real-time infectious disease data. Everyone's got their kind of separate space. And by putting them together, when some things go down, and it also shows where you shouldn't be putting effort, like wastewater data for RSV really lags and could go into that. Like we shouldn't be spending money on that. And so how can we look at kiddos going to the ER as a predictor for older people getting sick rather than spending money? So I think you see a lot of inefficiencies in how we spend money when you put the data sets next to each other as well, that we could be much more efficient in our data sets and systems.
Yeah, that's actually really cool. Like not only are you able to get some of this, you're able to get high level national information out so that people can take action locally. But also the wastewater thing, that's awesome. Everybody's wastewater. And you're saying nah, it doesn't really work as well as it could.
Not for RSV. It works better for other things, works better for flu. And part of it is because little kiddos get sicker with RSV and little kiddos use diapers. They don't use wastewater.
Mm.
So when you see little
Mm.
kiddos, they're more likely to go to the hospital. So that's why you see that uptake, but their waste isn't showing up in wastewater.
That
Versus
is a fantastic example that I would never have gotten on my own,
right?
ever, even though it totally makes sense.
Well, and I think you've been quoted in like various high-level publications about how wastewater doesn't work in Alaska because everybody's on septic.
Right.
And in
I'm
rural
like,
communities, we don't have sewer systems.
no.
Yeah, wait,
So-
did we all grow up on well systems or what? Like I
I sure
certainly
did,
did.
and
Like,
highly
yeah,
contaminated well water at that.
septic, well, you name
Yep.
it. Nice.
Always keeping it working. Yep.
Yeah.
People are like, it's the answer. And I'm like, oh,
No,
I mean,
you're like, I don't
you,
have
but-
one of those.
Yeah.
Like, what are you doing?
Yeah. Yeah.
So
not gonna happen.
2 questions for you. And so I would love if you could give all of our loyal fans some of the other, like, are there other cool insights that your team has been able to see, or others who are using PopHive data have been able to see that's like, oh, like this helps us change policy or should inform policy making because we weren't able to see it before. And then how are there state public health departments or public health authorities using PopHive now?
Yeah, so all sorts of states and local public health departments are using it. We actually now have a contract with ASTO to kind of be like, how can we make your world simpler, and how can you use your very limited funds to do more good rather than like each state recreating their own? Like use that basic. I think of it almost like the floor. Like you buy the couch, you buy the lighting, but we're going to provide the floor of the data, and then you can add on top of it with the space. So it's not going to tell you all the things, but it's going to help you kind of understand the space. Yeah, I mean, I think there's like a bunch of different things. So like the wastewater with RSV, Google Trends works really well for influenza and COVID. It doesn't, or influenza and RSV, it doesn't work well for COVID because that's very based on what's happening in the news. So other things like Google Trends doesn't work as well. Narcan searches on Google is very associated with people showing up to the ED with overdoses. So you can get really interesting Narcan. So we're about to release an injury and overdose website and dashboard. Public health thinks about birth data for chronic diseases. How can we cookie crumb them to thinking about EHR data or other data sets so they can see it better? So we just recently updated that space. There's this big narrative, I think, of like blue states versus red states and like who's vaccinated and who's not. But like you can go to our vaccine dashboard and you can change the vaccine type and you can see rural versus urban, Medicaid versus private insurance. And it's fascinating. Like every time I present to a state, I'm like, oh, I didn't realize Utah looked that way versus California. So you can go to your state and you can kind of, challenge your assumptions and be like, are we really as vaccinated as we think? Are we as bad as we think? Like what do we know in that space or not know? So those are some examples that you can see. We've actually tried to put on our website near the top, like explore these different things so they directly take you to that topic. And we actually have a Substack now that we're kind of highlighting kind of where we see trends in data. And we're also looking for partners who are using our data to highlight, like, this is how we used it. And this is an insight we did. And so we have actually just this week updated kind of a section of like, this is how this MedPage article, or this is how the LA Times, or this is how this, organization is using this data to make better decisions or to have more informed decisions. So we're trying to highlight and lift the voices of many who are using data in different ways. And
is our great federal government working with you now?
A great federal government is not working. I mean, we use government data. So we've downloaded a lot of the Medicare data. The Medicaid data is a great example. Like we're trying to figure out, like, can we display the Medicaid data and the data use agreements, to Lisa's point about like, this is publicly available data, but like we really want to display it. So we're having our lawyers and other team kind of look into that space. We're not directly working with them. Again, my focus has always been the patients I serve and the people. And that is 100% where this is aligned. And I think that if we have the private sector, academia, government all aligned to doing that, we're going to do better in this space. So very much looking forward to partnering with everyone in how do we serve people so that they've got the information they need to be as healthy and well as possible. We are also looking with like some AI organizations, media organizations on how to use this data to better inform conversation and media. And how could you have large language models sit on top of it to say like, how's Los Angeles looking at X, Y, or Z? Again, you need to sit on top of it so you can ask questions.
Yeah, I was going to ask
this
about
is a big trend right now, right? A big trend in the sense of like, a lot of folks, including everyone working on Pop Hive, trying to figure out how to, fill the gaps that were left when big parts of the CDC were defunded or shut down.
Mm.
And, I think, it's safe to say this is one of the most credible efforts, and people should get involved and figure out how they can help from a like industry side and a state side and a organizational side. But yeah, I mean, I think it would certainly be very interesting. I would think for the foundation model companies, for companies like the one I work for, or folks who Incenna works with, right, to figure out like how could we support, what could we do to help, and can we, also work with the data sources as well to provide better stuff to all of the healthcare industry, enterprise that we serve.
We would love that. I think in general, we're looking for three things.
Public health.
Like, what data is out there that we could sit on top of or highlight to be able to share it? What data are we sharing, and can you use it to make the world better? And how can you communicate that? And we're highlight it. And then what way can we make this a funded, sustainable effort so that we don't go through these like waxing and waning, boom and bust like state? We're always going to need like state to have some information to be able, and some data to investigate the, Ebola outbreak, or to look at what's happening with that Giardia component. But there's huge population health data that we can do much more efficiently, much better. And we're a small, nimble, fast team, which has made it be able to respond to things that are happening, and excited to make it last in perpetuity.
Amazing.
Can you say again where people should go to find you and find Popeye?
Yeah, super. www.hive.org. So Population Health Information Visualization Exchange.org.
Amazing.
Love
we love
it.
a good acronym.
Love it.
And email us. There's an info. Send us info. We're always
Congrats.
For people.
Thanks. Like I said, as someone who's tried to get a bunch of data together for a long time, but with commercial interests, I didn't believe you when you first told me you were doing this. I was like, you're right. But it's happening, and that's awesome. That's awesome for America. It's awesome for me. It's awesome for you and Lisa. Yep. So thank you very much. And like all of our loyal fans, go check out pophive.org and help Ann out.
Yeah. Awesome.
All right.
Well, thanks for having me on here, and thanks for all you guys are doing to keep the world in data.
Yay! That's one fake news story at a time. All right.
That's right.
Thanks, America. Have a great weekend, and probably a good New Year.
Probably have a great end of the year.
We'll talk
See you soon. Bye.